What I would like to ask you is, are there any studies at the moment going on that would help patients with their physical well-being?
Yes, there are some new studies that are just beginning and some that will soon to report. So there's one that springs to mind from London, the IMPACT study, which is looking at physical health in schizophrenia by virtue of an attached worker in the community who's given a package of lifestyle physical health advice to patients, monitoring them at baseline, giving the advice, following them for, I think, a year initially and then 18 months altogether, and then seeing, as it helped, physical health profile. I'm involved in a study which is based in Sheffield called Stepwise, which is essentially a group-based intervention. You can think of it almost like peer support, but actually it has another element, a very strong element, which is proven successful in diabetes. So they've taken lessons from diabetes, and one of the models that's been quite effective is a kind of educational program which caused a kind of culture shift, particularly amongst people who are involved in that person's care. And that's called the Desmond Project from the Leicester group, Melanie Davis and colleagues. They're going to use that program, modified for severe mental ill health, particularly schizophrenia, and in a randomized control trial, randomize half of the group to have that intervention and half to have usual care. Usual care may be very little, as we were kind of discussing, or it may be more these days because there's more guidance, there's more awareness of the issue. So usual care itself could be improving over the course of this study, which is going to run throughout most of really the end of 2014 and 2015. And then, rather like the IMPACT study, it's going to measure the effect on the well-being of the patient, particularly for things like has the increase in weight that would be anticipated with antipsychotics in the treatment as usual group been offset by the intervention group. And in addition to that, has diabetes been offset? But we might look further on about other general well-being markers as well. So those are two studies I know of. But there's been another very large study reported actually from the States in the New England Journal of Medicine. And that's from Gail Dammit. That's D-A-U-M-I-T. And she looked at a very, very intense program of mostly class-based, by that I mean exercise class-based intervention for patients with severe mental ill health on antipsychotics. And they started with quite an at-risk group where the BMI, that's the body mass index, was around 30, and the weight of the patient was around 100 kilograms, so around about 15 stone or more. And what they found is that they offered patients nearly 250 sessions over 1.5 years. But the patients only attended 31% of the offered sessions. And there was a modest effect, but the modest effect was in the region of 3 kilograms or so lost. But when I'm describing that patient sample, the patients were, roughly 10 to 20 kilograms overweight above their, ideal in a way. So that 3 kilograms lost was a little bit disappointing, and that was a very intensive program. It had quite a powerful inbuilt mechanism, which is class-based exercise activity, which clearly, if somebody's actually engaging in it, could be seen as the gold standard, here. But yet, what they didn't do is recruit patients all very early in the process. They recruited patients relatively late. That particular study in New England Journal of Medicine could be seen as what happens if you do something very intense but late. The outlook is really not good. There are some medication studies, and we're going to see a lot more of these. The ones I particularly favour at the moment, because there's at least 6 in the literature, are the metformin studies. Metformin is an insulin sensitizer, which has been trialled in diabetes to offset diabetes in somebody at risk, either somebody who's overweight or somebody who's got pre-diabetes. In the studies from Wu, that's W-U et al., when they've used metformin early at the same time as prescribing the antipsychotic from day one, it's really offset a lot of the weight gain that patients would have if they didn't have that co-prescription of metformin. And there were other stronger, in theory, stronger drugs, which we're learning a lesson from the diabetes literature that may be effective, but we've got to be cautious about multiple prescriptions. And you could theoretically introduce even newer side effects from your second drug. So, of course, prescribing drugs sometimes isn't the best strategy for this area. Generally, the first line intervention is considered to be lifestyle, which is about diet, it's about exercise, it's about methods to keep active in general. It's about healthy living, in general.
Well, what comes across clearly is early intervention is extremely important in this whole sphere.
I think so.
The other thing that you just touched on, but possibly isn't something with schizophrenia in mind, is peer support something that would help patients take more interest in their ongoing treatment if they had other people to talk to?
Well, definitely it's beneficial in most conditions in terms of well-being and feeling more confident with your condition and more informed. So those kind of universals are definitely helped by peer support. But does peer support particularly address the issue of weight and physical comorbidity? Well, we know peer support works to some extent from things like Weight Watchers, which is basically a peer support model with an instructor or a charismatic leader. That must work because it's actually, that industry based on those kind of classes and peer support is worth, millions of pounds or dollars, isn't it? So there is a lot in that. But I think we could do much more there in the arena of mental ill health from the perspective of physical comorbidity. But not just that, it helps well-being in general, as we just said. So it could just be built into a program. Physical ill health, weight, diet, exercise, activity, they could all be built into a program which was discussed in a peer support setting. And I think that would help a lot. Now you do find in certain units, they do have this set up ad hoc. They already know it's a good idea and they're running it and they'll say it's great, but not many of these programs are written up. Not many of them are written up. Some of them have been written up in weight management of schizophrenia. For example, a chap from Manchester, John Pendlebury, worked on a program to offset weight gain in schizophrenia related to atypical antipsychotics when they pretty much came to market. And he showed that weight gain was offset and many in his group did lose weight. It was pretty intensive and hard work, but basically he showed it. But it wasn't a randomized controlled trial. And to really prove it, people want that high level evidence from a randomized controlled trial. And that is where why I referenced those 2 studies earlier from London and from Sheffield. They are randomized controlled trials as far as I understand.
Surely there should be more publicity then, basically, about schizophrenia and how patients with schizophrenia are going to be affected, and more people taking on board how they could help in this particularly important issue.
I agree. Publicity is definitely important, not just for the clinician. The clinician's awareness is raised by publicity, by journal articles, by word of mouth, by seeing what colleagues do, by national and international recommendations. But really, all of those things go together to making a culture shift. And that culture shift is aided if the patient considers it's a problem. Now let's take weight gain. Weight gain is a major issue because I said that the majority of people on one of our newer drugs will gain weight. Actually, about 80% will gain weight on the medication. But if you ask patients, and this has been done in that second wave Australian psychosis survey, how much do you think your weight has been contributed by your medication? The answer they got was 40% of patients said that their weight had been significantly contributed to by the medication. Now, I think it's more than that, and the figures show it is usually more than that, but that's the percentage you were saying, yeah, it's a problem for me, I'm bothered about it. Now, weight does affect stigma and it does affect self-esteem, but sometimes it can be underplayed as well. In other words, if it's not clear to the patient that it's been made worse by their condition or their medication, and moreover somebody's prepared to help them do something about it, they probably won't raise an alarm. It'll probably go unmentioned. The clinician then may or may not do something about it unilaterally. But really this collaborative model where the patient raises an issue and the clinician works with them in trying to help it is really best. Now, what we've actually learned somewhat painfully over the last 5 to 10 years is that that's got to be done early. It's actually too late to leave the problem for years and then say, oh, look, we've got heightened awareness of medical comorbidity and let's say diabetes or weight, and then try to fix the problem rather late in the day. It's almost impossible to recoup the amount of damage done from our various strategies and the background lifestyle issues, whatever contributes to excess comorbidity. It's almost impossible to recoup it. So for example, in terms of that weight increase, it's hard to claw back that 12 to 15 kilos, that 2 to 3 stone that people tend to put on with psychiatric treatment if they've got schizophrenia and they start on antipsychotics. So the intervention, whether that's a medication to help with weight and prevent later diabetes, whether it's a lifestyle, whether it's classes, whether it's information, or whether it's peer support, there's various models that might work. Whatever the model, it should be started early. And by early, I mean straight away, at the beginning of treatment, not later. It should go hand in hand with the start of treatment. In other words, if we're going to start prescribing a medication that's going to make things worse, we should be giving a mechanism to offset that from day one. That's partly the strategy I think we need to adopt.
So basically, patients with schizophrenia ought to know right from the beginning what side effects they might have so that they're in a position to counteract them straight away.
Yes.
Rather than let them build up over a period of time.
Now the problem there, put yourself in the shoes of the clinician who's got an unwell patient in front of them and they want to prescribe a medication which they believe to be effective and probably is effective at treating the schizophrenia. But the clinician knows now that medication comes at a slight cost. That cost is not immediately apparent after a day or two. It's apparent after a few months usually and accumulates with time. Are you going to say to the patient, I'd like to prescribe this new medication. In my honest opinion, it will help your condition. But I have to tell you that you may get these side effects. It's very, very likely you're going to gain weight from that. You may develop diabetes if we don't do something about it. It could adversely affect your lipid profile, and if we don't do something about it, there could be a knock-on effect in terms of your general ill health. That's quite a scary statement to make to somebody at the start. Most clinicians are not going to put things in those terms, even if the clinician believes it. Now, I do believe that ethically you have to tell the patient what side effects are likely. But if the clinician is prepared to attend to, let's say, an offsetting strategy, sometimes in medication terms that's called co-prescription, where you start a drug that actually is offsetting the side effects of the main drug. I know you've got the problem there prescribing 2, not 1 drugs, and the hassle for the patient shouldn't be underestimated. But the point is, if you're actively offsetting the problem occurring, then you don't need to raise such alarm about the possibility of those side effects accruing. It's reasonable to give a briefer version that there's a chance that you may gain weight, but I want to attend to this by doing the following. And I want you to work with me and we can offset it. But of course, the clinician must also give the alternatives to those. And sometimes where the patient's very unwell, it's quite hard to have that conversation. And the clinician may have today and tomorrow in their mind, how to help the patient today and tomorrow. and they're not so concerned about next month because their objective is getting the patient well today. And I totally understand that perspective. That is really the clinician's dilemma. It's a hard one to get out of, but I think there's a kind of compromise there where you have to decide to work with the patient, particularly on areas that you're exacerbating by virtue of your treatment.
I would have thought quite a few patients, though, faced with that problem and told firsthand, if you take this medication, you may have certain side effects, but we can sort that out. That most people would still take that on board and take the medication and follow through, trusting the clinician.
Yeah.
So surely it's still better to tell them as soon as possible.
I think I agree with you, and I'll tell you one reason I do. If you don't tell the patient and wait for the problem to accrue and then try to intervene late or don't intervene at all, the patient's left with the problem. What the literature shows is that patients have a high rate of discontinuation later in their condition, often due to side effects. About half of discontinuations will be attributable to side effects on some level, even if the clinician isn't aware of them. And some of those discontinuations, not an insignificant number, are unilateral from the patient. The patient is prescribed the medication, but they just say, look, I've had enough, I'm stopping. And they may or may not tell the clinician later that they've stopped the medication. Obviously, if they come back to clinic, the clinician inquires, usually they find out. But the point is, why put the patient in that unfortunate position? An upfront discussion enables the patient to anticipate the side effects, hopefully not over-anticipate them, but anticipate them in a way that they can say, I feel this is developing, can you give me a suggestion here? In other words, they can raise it. They can raise it as a potential problem with their clinician and expect the clinician to attend to it, rather than just think, oh, is it just me who's developed this? I don't know whether it's due to my drug or what, so I'm not going to mention it. It's, I've not got the confidence to mention it, either the confidence in myself or the confidence in my clinician to actually attend to it. So having the conversation early improves that confidence or therapeutic alliance.
I think it should become second nature for it to be almost automatic to be discussed right at the beginning as a sort of a way of talking to the patient. This could happen, but don't worry, we're sorting it out.
Yes, where possible.
Follow through by monitoring.
Yes, I would agree with you. Where possible, that should be the case. And backing up the system by monitoring, routine monitoring, that would get round the problem of issues developing where the patient isn't necessarily aware of it. I mean, a classic example is diabetes. When diabetes starts early, in those early months or years of diabetes often not manifest clinically with very strong symptoms and signs. Many people are not necessarily aware they have diabetes. In the general population, the rate of diabetes using the kind of classic markers of diabetes, the biochemical markers, is around 4 to 6%. But at least another 2 to 4% probably have diabetes in the general population and don't know about it. They're undiagnosed and undetected diabetes. There's a larger number who have pre-diabetes where the glucose and insulin are becoming dysregulated. The glucose level is often becoming high. That is the basic definition of diabetes. The insulin level, people think the insulin level is low, but the insulin level starts high, trying to compensate for the high glucose. So in that phase of pre-diabetes, if we intervene then, we can do something about it. Now, in schizophrenia, what is the story? Well, the relative risk of diabetes compared to aged match controls is about 4 to 6 times. It may even be higher than that in schizophrenia. The actual rate of diabetes in schizophrenia of those with established illness who are on these drugs that we were talking about before, the actual rate is about 12 to 13% of diabetes. In one of the largest studies that I was involved with Mark de Hert in Belgium, they found this rate of about 13% of core diabetes, which is clearly a major concern. but another 40% had pre-diabetes, a glucose abnormality that wasn't yet diabetes, but wasn't normal, that was getting worse and likely to transition to diabetes in time. About 10 to 20% would transition each year to diabetes from that pre-diabetes group. And pre-diabetes is associated with some abnormalities in general health anyway. So pre-diabetes is not a good state, but it's the perfect position to intervene. It's the perfect position to intervene. And the diabetologists have done some really excellent studies. For example, the Diabetes Prevention Project from the US, which looked at 1,000 people randomized to either lifestyle, medication, or lifestyle and a medication option to prevent pre-diabetes going to diabetes. Now, what I'm saying in schizophrenia is half of the population that we're dealing with probably have either diabetes or pre-diabetes, and half probably have normal glucose regulation. That's in a middle-age cohort. In an older cohort, the figures are worse actually, because diabetes gets worse with age. So in the middle-age cohort, about half of our patients have a concern that we should be testing for and measuring and then doing something about. But we're not coming up to scratch in those areas, and we need to do more. So diabetes is a very interesting condition which has a lot of similarities with severe mental ill health, but where it co-occurs with severe mental ill health, it's very common but not attended to. And there's a message. The population out there knows a lot about how important diabetes is. There's a lot of education out there about diabetes, but we've got this outlier of patients with mental health. We're actually making the problem worse, I have to say, with our medications. The background lifestyle, diet, exercise, fitness capacity, they're all predisposing to high rates of diabetes. And that's not to mention weight and obesity as well. So there's a lot of lessons there that we need to learn, and we need to learn these lessons really quickly because our patients are currently suffering with this problem, and we all need to work together to do something about it.
Surely with patients with schizophrenia, the diet angle should be paramount. Are patients automatically given a diet sheet, advice, see a dietitian straight away to preempt things turning into, for example, diabetes, being on a diet? I mean, we talk about a healthy diet, but surely in schizophrenia it's even more important.
I totally agree with you, and believe it or not only are they not giving it straight away, they're not giving it at all. They're not giving it at all. There's really no big effort in most hospitals to do something about unhealthy diets in schizophrenia. About 2/3 of patients with schizophrenia are falling into that category. Less than once a week, healthy, balanced meal. In my opinion, we're hardly doing anything about that. We're hardly doing anything. And I'm guilty of that too. For some reason, that has been left unaddressed. Now, sometimes some units do have a service for patients with obesity, and they do get involved and start to give advice. But in my opinion, it's rather too late at that time. And of course, once diabetes develops, yes, a dietitian tends to get involved. But I actually think that a dietitian should perhaps be attached to large units and see patients with a mental health concern as a routine, not if there's a massive problem. In other words, we can think of this group as a group at strong risk of a lot of lifestyle factors, including diet. And we should then automatically try and help them, rather than wait for a problem to accrue and then say, oh, quick, send in the dietitian. That's probably not the best strategy.
I would have thought it would be much more cost effective to start at the beginning and say, look, you're going to be on this medication. Let's give you a diet sheet which will help complement what you're taking and nip it in the bud, really.
Yes.
If that became common practice, surely that would be a far better way of approaching the problems that might come in the future for somebody with schizophrenia.
Yeah, I would say start early. We're talking here about particularly people with so-called first episode psychosis, where they've got a relatively small duration of illness, and haven't been on medication either at all or for a long period of time. Actually, not being on medication and being a normal weight and being a young person, those are all risk factors for an unhealthy lifestyle occurring, believe it or not. In other words, increasing weight, for example, with medication, those are all risk factors for increasing weight with medication. So that is the perfect time to intervene. And we need to build in a kind of physical health package with our mental health package as well, beginning very early. And by early, I mean straight away, as soon as we have contact with the patient.
Yes, I definitely think that what you've said there about having the two together would make a tremendous difference if it started at the beginning.
Yeah.
And thank you very much for all the information you've given us today.
My pleasure. Thank you.
Thank you.